Welcome everyone to the webinar organized by RHSC Advocacy and Accountability Working Group, entitled Where Everyone is Accountable, Everyone Wins, Tools and Tactics from the Advocacy for Better Health project in Uganda. This webinar will be talking about the USAID-funded program Advocacy for Better Health. It's a 5-year project implemented by PATH and initiatives. Launched in 2014, the project aims to empower Ugandans with the skills, tools, and systems to effectively advocate for accessible, high-quality health services. Advocacy for Better Health builds the capacity of communities and civil society organizations to identify the gaps in health services, engage with responsible duty bearers, and demand accountability for health-related commitments. Across 35 districts, 479 sub-counties, and at the national level, more than 20 local CSOs and hundreds of community groups are making their voices heard and spurring change, from health workers at the facility level to local government officials, all the way to parliamentarians. Today in our webinar, we have 3 people in our panel. The first person is Moses Dombo. He's the Chief of Party for USAID's Advocacy for Better Health project in Uganda. Moses will be providing an overview of the project and its model, which emphasizes 3 distinct but interrelated strategies: citizen mobilization and empowerment, social accountability, and policy advocacy. After Moses, we'll have Hasifa Nalunjiga. She's a Senior Advocacy Officer for Advocacy for Better Health and oversees the project's reproductive health portfolio. Hasifa will be sharing a national-level advocacy win that is improving the availability of oxytocin in Uganda's health facilities, as well as the tools and tactics the team used to achieve this success. And last, we have Josephine Kikonko. She's a District Advocacy Officer for Advocacy for Better Health, where she supports community groups and CSO partners in Uganda's western region. Josephine will be presenting on a community-led initiative to improve accountability among local government officials and service providers, and how this has translated to better access to health care for women. At the end of the session, we'll have some time for questions from the audience. There are 2 ways to raise your question. The first way is you can type your question in the question box that you see in the GoToWebinar box on your screen. If you type in a question, your question will be raised by myself to the speakers. Second option is that you can raise your virtual hand by clicking the little hand in the right upper corner of the GoToMeeting box on your screen. That way I will know that you want to raise a question. I will unmute you and you can raise your question yourself. So with this practical information, I would like to give the floor to Moses. Moses, the floor is yours.
Thank you very much, Emily. Welcome everybody, and good morning, good afternoon, depending on where you are located. Advocacy for Better Health project in Uganda is, oh, my screen is not moving, why? Can you release my screen so it can move down? Hello? Ena, my screen is not moving. I wanted to start by moving my slides. They're not scrolling.
Moses, I think the problem is on your side. Is that possible? Can you use your arrows?
I'm using my arrows and it's not moving. I don't know why. What has happened? It's frozen. Well, I can continue to talk about the project, even because I know the project. I don't know why the slides are not moving. I want to hope that they can start to move. Can you move?
Yeah.
Okay. So, thank you very much. So this is a project that is implemented by PATH in partnership with Inc. Initiatives Inc. It is funded by USAID for 5 years. We should be closing shop at the end of May next year. We have had a budget of nearly $20 million to work with, and we focus on enhancing the capacity of civil society organizations to represent citizens' interests and conduct advocacy strength health-related policies and budgets. Our main goal is to improve the availability and accessibility and quality of health and social services in Uganda. I'm moving to the next slide. Our theory of change in this project is we believe if the citizens can be given the knowledge and the awareness of their rights and responsibilities, they can be stimulated to work in partnership with civil society organizations whose capacity will be built or is being built to demand for better accountability and better services from their service providers, especially those that are responsible for making decisions. I have moved to the next slide. The Advocacy for Better Health model has three major pillars. We have the citizen mobilization pillar, which I've already mentioned. We have the social accountability pillar, and we have the policy advocacy pillar. It is noteworthy that we work through civil society organizations. These civil society organizations have direct contact with 479 community groups, and we work mainly in the areas of reproductive health, maternal and neonatal child care health. We work in the areas of HIV, AIDS, TB, malaria, and nutrition, among others. I've gone to the next slide. And on the next slide, I describe in some detail our community empowerment pathway. What basically takes place is that once we work with the communities to build their awareness of their rights and responsibilities, then the communities take up the responsibility to monitor and track service delivery. And they go on to create advocacy action plans through which they agree to meet their duty bearers or their decision makers to demand for specific actions. And the interface with duty bearers is conducted through a number of ways, some face-to-face meetings, and sometimes the duty bearers are brought to forums where they then interface with entire communities to discuss issues. We work through media and advocacy champions. On the next slide, I have a photograph showing two gentlemen. One is an advocacy champion, the other one is a media champion, and they work together to amplify the voices of the communities and take these messages to the next level. We work by promoting social accountability, accelerating advocacy voices, as I've said. On the next slide is a photograph of people meeting the Speaker of Parliament and the Minister of Health to specifically enhance voices on specific issues of concern. At that particular time, we were discussing, among others, stock out of drugs, especially for HIV, AIDS, and TB. We work on the next slide, we work on three major health system strengthening priorities for advocacy. We have the domestic health financing budget. We've been working together with the Parliament and other civil society organization coalitions to push the government to increase its share of budget to the health department. We've had successes and not sometimes some challenges, but overall there has been a lot of improvement. We also focus on the area of health commodity security, especially issues of chain management, supply chain management, and drug stockouts to make sure that these are managed. We also work in the area of human resources for health. And then, as I've said, our major thematic areas on the next slide, we focus on HIV/AIDS, we focus on TB, mainly socializing the 90-90 treatment goals. MCH is really strong, reproductive health, nutrition, malaria, and TB. On the next slide, we've had some very innovative ways of doing advocacy. We had the presidential dialogue, which we held. The first presidential dialogue was held last year. We are planning the next presidential dialogue for this year. We have given communities materials that facilitate them to move around and conduct their activities. We also partnered with some lead musicians. Our own Beyonce is here. We partnered with 6 leading musicians to develop and craft messages on advocacy, which they present in songs. And these have proved to be very effective, as the songs are played almost every other day. Now, on the next slide, we do partnerships with other organizations. They are the 22 through whom we work, but then we also partner with others through coalitions and task forces. And we are operational in 35 districts, which represents nearly 25% of the country. On the next slide, we have developed some very creative and supportive tools that other actors can actually utilize. Tools for mobilizing citizens, for holding leaders accountable, and for advocating for policy change. Practical tool set, which includes 5 books, or in our package, we have a package that includes 5 booklets focusing on specific components of social accountability, advocating for better health, mobilizing communities. And these are tools that people can take and utilize. They show the what and the how of what we do. These are available on both on our website as well as in hard copies upon request. These materials on the next slide can be found on that Advocacy for Better Health website, and the address is right there, www.advocacyforbetterhealth.com. In a nutshell, this is the project, and I would like to leave it at this stage and hand it over to my colleague Hasifa to share specifically some practical examples of some of the things we've done using one particular case study.
Thank you so much, Moses. My name is Hasifa Naliga, Senior Advocacy Officer, as I was introduced by Ina, and I'm sharing a case study of oxytocin availability, where Advocacy for Better Health through national and district initiatives, we advocated for availability of oxytocin. The issue is, we know that maternal mortality ratio in Uganda is very high at 336 deaths per 100,000 live births. And we know that postpartum hemorrhage contributes almost 34% of the deaths. And that's how we picked interest of advocating the availability of oxytocin that reduces, prevents, and treats postpartum hemorrhage. So oxytocin is a life-saving commodity, and you know that it is always supposed to be in cold chain storage as recommended by WHO. And in Uganda, oxytocin is used at high-level health facilities, that is health center 3s, that is at a sub-county level, and where women give birth and there's a cold chain capacity there, but we know that sometimes births happen at the lowest level, which is health center 2 at a parish level. And though oxytocin is included in Uganda's RMNCH quantification and supply plan, it is often unavailable because the stocks sometimes run out. So we gathered evidence about the issue. We did a desk review, and we compiled evidence, and validated with the partners. We had a meeting with several of them who are interested in RAMNAC, and then found out that it's not only an availability of oxytocin that was the issue, but the quality of oxytocin was compromised by the poor storage, and we had to also embark on advocacy for the cold chain for oxytocin to be able to control quality, to improve on its efficacy. So community groups conducted health facility assessments, which revealed stock out of oxytocin, and the community groups always do like monthly visits to the health facilities to establish the availability of so many things, the areas that Moses mentioned, the human resources for health, and then the availability of commodities. And they established that almost 60% of health center 3s did not have fridges in the maternity wards, so that compromised the quality of oxytocin. And then the reliability of electricity, where there are fridges, so they are not working because of poor electricity supply. And then communities' findings informed national level engagements. We have a framework whereby we pick issues from community, and then they are amplified at national level. So At national level, we have CSOs which did a desk review to establish the gaps, and then that information was backed up by the facts that were found by the community groups through the facility assessments, and then we had to package our information. Then presented the evidence that we had to maternal and child health technical working group in the Ministry of Health. It's a technical working group that brings together several players in maternal and child health arena, and then we presented the issue and the magnitude of the problem and its effect on the maternal health, which was a problem. And then we built consensus, the people in the meeting, and everyone agreed that we had to resolve the issue of storage of oxytocin, because even where it was, maternal deaths were rampant because it was stored outside the cold chain. So when we did that, we presented it in the MCH cluster, and it was picked. It was an interesting topic for everyone, and then they presented it to Ministry of Health top management, and the top management of the Ministry of Health has the top decision makers, where the permanent secretary issued a directive to all district health officers, which enabled the storage of oxytocin in the Uganda National Expanded Program on Immunization fridges. Originally, it was a law that they're not supposed to store any other drugs and immunate fridges because they are supposed to be for vaccines. They feared to mix up drugs and vaccines. So here it was like a solution, a short-term solution to address the storage of oxytocin. And so that directive for us, it was a quick win, because at least the issue will be resolved in a short term. Then the next steps, MOH was working on procuring fridges for maternity wards under the GFF program. And then ABH is continuing to advocate through the coalition that we have. We have a maternal health coalition that advocates for issues around maternal health. So we are continuing the advocacy to ensure that at least the fridges are procured for all maternity wards at all health center facilities. We learned some lessons in this, that we said it was very important for us to have facts on our fingertips, to package it so well that we managed to present it to the target audience, and because it was credible information, it was first-hand information for the communities who access services at the facility. And then it was critical to know decision makers' interests. The maternal and child health technical working group chairperson is a supporter or a champion of maternal health, and she was once leading a UN Commission on Life-Saving Commodities project, where oxytocin is one of the commodities that she was advocating for its availability. So after learning that she's very much passionate about this, we used that interest and then actually presented to her. She did not hesitate to present it to the top management. Again, coalition building is very key than standing alone. We thought going together, strengthening the voice of civil society organizations was very key, and it helped us to amplify the issue at all levels. Then persistence and the repetition, because every month we have the technical working groups, and we always go there, and once the issue is presented on the agenda, they'll keep asking about the progress until you achieve what you had anticipated to achieve. So persistence and advocacy and the repetition really helped us to achieve what we achieved. Along the way, we learned a few lessons, and the gathering evidence about the availability of oxytocin and cold chain storage at the facility level using ABH's health facility assessment tool. On the side here, we show the tool where the community groups use to going back every now and then to track the availability of the drugs, and then building the capacity of CSOs in advocacy strategy development using the 10 parts. They were able to identify the issues, they were able to identify the right audience, they were able to package the evidence, and they were able also to engage with the duty bearers who are responsible to address the issue. So building their capacity helped us to achieve the success that we achieved. Thank you very much. I'll hand over to Josephine to take us through the community part.
Thank you so much, Asfa, and the audience listening in. Listening from the whole perspective and the general presentation from the national level, I bring in the sub-national, or what we could call the district advocacy based. And this is I'll bring a case story from Kisoro, one of the districts in Uganda, in southwestern Uganda, bordering Congo and Rwanda. Busanza, we picked interest so much in Busanza because there were various issues happening in Busanza, lots of challenges like ambulances, absenteeism of health workers, and the community finding it difficult to access the quality healthcare service that we desire to have. We believe that every Ugandan deserves to have quality healthcare. Among these challenges, we realized that there was something that could be done, and why we called them challenges or advocacy issues is the fact that it was becoming so challenging for a common patient, for a common mother who is going to deliver, to move distances to go for delivery in the government hospital, which is in over 20 kilometers far apart, and with bad roads to access the hospital. We also realized that the absenteeism of the ambulance at the facility was causing a high cost for the patients to pay in or to hire a vehicle, which was ranging from 40,000 to 100, based on where a patient was going to be picked, and that ranges between 10 to 25 USA dollars, which is not affordable for a common citizen who needs the services. What created it to be a very critical issue was the loss of a mother, and a baby due to failure to secure transport to the facility after the patient had been referred from a health center to a hospital. ABH, Advocacy for Better Health, came in at the point when the community really needed to come on and voice out their challenges. And as Moses explained it, that one of our pillars is community empowerment. You want to see where citizens drive for change and desire to move to have their duty bearers take action in their issues. And this is what we did as the project. We identified the community advocacy group, and this was through the mapping process. We do not form independent groups, but we work with already existing structures. So an advocacy group was we identified one of the active community groups within the community, which would support us in voicing out the issues. In that process, after the mapping, we took them through a series of training, and of which among the key ones was to guide them in development of an advocacy action plan, and then support them through the processes of implementing that advocacy plan. It's a step-by-step plan. It is not a one-day activity and then the issue is solved, but they come up with key activities that they feel can help them achieve the desired goal, and that is what entails in the action plan. The advocacy for better health through the supportive tools, like HASFA presented the health facility assessment tool, used those other advocacy tools to gather and package their evidence for engaging with duty bearers. Advocacy also supported them to do the follow-ups and to raise their concerns through meetings, forums, and others, which encouraged the decision makers to be concerned on the challenges the community was facing. And then we supported the group to do the follow-ups on the commitments that the decision makers made in the other engagements that we had, and then helped the group in documenting their success stories. That was what ABH and the community responded to. Among the tools that we mainly used, like mentioned, we had the health facility assessment tool, we have the advocacy action planning template, we have the minutes templates for community action plan meetings and advocacy forums. Why we use tools, we realize that in advocacy, documentation is very key. It helps us track progress, it helps us follow up, especially when it comes to the commitments made. Meeting minutes are very key. That is why we came up with a minutes template to guide the community groups in advocacy forum. The methods of evidence gathering that we used, we had key informant interviews where we held them with patients and then health workers, facility visits, testimonies, and observations, among many others that the community group used. What was our win in this case scenario? We realized that as a result of the series of engagement and support this community group, the challenge of transport, like expressed, we had the issues of the ambulance was returned back to the facility, and no longer personalized by the driver, the Health Unit Management Committee allocated funds from the PHC grants that they usually receive from government, which was set aside to facilitate the referral network, especially that disadvantaged patients or clients who were unable to pay for the transport to the facilities. The absenteeism driver was dismissed from the payroll, from the district payroll, or was dismissed from the government service, and then a new driver was recruited to support the functionality of the ambulance. We saw the Health Unit Management Committee putting up monitoring mechanisms to ensure, for example, the accommodation for the health workers, accommodation for the driver and others, to cut down absenteeism and to ensure that there is at least a driver to run the ambulance and manage referrals day and night, which the community appreciated so much. And now we see the referral system has really functioned. A patient can easily be referred from this point of health center to the district hospital, or any other area of service where I can access a service at ease. And even in difficult where there is inability, there has been a way that the community has been supported by the health facility to manage all those cases, and which the community feels they are voicing out issues has helped them. But in all this, we've learned key lessons. We realize that in advocacy, issue ownership by citizens is important. When an issue is championed by the community members and they feel they own it, they feel that is their issue, it affects majority of their community members, then they will want to achieve a lot of success on it. They have that desired goal to see a difference, and that is what pushes advocacy or its success in any of the ventures that we go for. Then there is a collective action planning, which helps the communities identify challenges in the health delivery and also create the strategic advocacy plan to demand for change. We realize that for every community to move on, and that is what we learned greatly, there must be a collective action plan. Advocacy is systematic. It must work from one point to the other. It is not a jump on activity and then results are there. So that systematic and collective action is what we learn that can drive great change. We have community-generated evidence, which is also key, and we learned that with evidence, you can convince the masses, you can convince the duty bearers, and you can drive for change. No evidence, no success. So that was also a great lesson that we learned out of it. And we realized that documentation is key, and more so when it comes to following up of commitments. Like mentioned above, we said we have developed tools like minute templates, we have action plans, and all those help us to follow up. They help us to track progress, and they help us to really engage duty bearers at a better point. So if you're into advocacy, document, and every step matters. You never know which step will help you accomplish your goal. Thank you so much. Where everyone is accountable, everyone wins.
I would like to conclude by saying that for all the tools that we have mentioned, you can reference, we've documented ABH's approach to policy advocacy in the portfolio, and the tools are all available that you can access them.
Thank you very much. Thank you, Moses, Hasifa, and Josephine, for the very interesting presentations. I'd like to remind everyone that you can ask questions by raising question in the question box, writing it down, then I can ask it to the presenters, or if you click the little hand that you have in the box, then I can see that you would like to ask the question. I can unmute you and you can ask the question yourself. So please don't hesitate and ask all the questions that you want. I'll start with the first question from Jill Gay, who asked how you've been working with healthcare providers to avoid discrimination and abuse and stigma against people living with HIV. I don't know. Have you worked with the healthcare providers on stigma and discrimination?
Yes, we've worked on the issue of stigma. Actually, as a matter of fact, we have worked in partnership with the National National Forum of People Living with HIV/AIDS in Uganda, which is a network of people living with HIV and AIDS, covering all the districts in the country, to develop an anti-stigma policy and guide. That is in its final stages of production, and we've done that in partnership with UNAIDS and NAFOPANO and the government of Uganda through the AIDS Commission. Hasifa can actually say a little more because she has been the architect of this.
Yeah, I just want to add on what, that we also have community groups who work as like champion clients and linked facilitators between community members and the health facilities. So they have helped a lot to address the issue of stigma and improving access to services for people living with HIV/AIDS at health facility level.
Okay, thank you very much. And then another question, you've been raising lots of different topics and I guess lots of different ways to do advocacy. Can you give some more explanation on how many people you are, how many advocates are working on this? Because I can imagine it's quite a lot of work if you see all the different things that you're working on.
In terms of the human resource or the workforce, we are certainly very many people. The project itself is pretty small. We have a total of about 25 staff, including support staff and professional staff and technical staff, plus management. But the number of staff that are resident with the civil society partner organizations is almost 2 to 3 people per organization. And that is amplified further by a large army of volunteers in terms of the community groups that we partner with, 479 groups, each with an average of 30 members. And then each of those groups has a champion, an advocacy champion, and also they have media champions out there with whom we work. So it is and then we have an advocacy advisory group at the national level. All those are people that are available to provide technical input and support to the project. So that the number of staff, small, many volunteers, many willing hands out there. And of course, the communities themselves. Once the communities get educated, get awareness, they are enthused and they feel like going forward. So I believe the number of people is really significant out there who are involved in this process.
Can you maybe give some advice for other advocates on the call on how you build a strong relation with all these other organizations, with the volunteers, to make sure that you're all working towards the same objective?
I would say one brick at a time. It's one brick at a time. People think advocacy is easy, and sometimes people think advocacy, you just open your mouth and talk. But people need to have the skills to get people to listen to them, but also the skills to identify issues that are pertinent, and then to gather the evidence, and then to package that evidence and present it in a manner that compels service duty bearers or government officials, public officials to take action, to respond to the issue. And then also it is always important to take back accountability to the people. People need feedback. Once people see that their advocacy efforts are bearing fruit, then you will get so many people volunteering information and coming to work with you. Building effective coalitions is very important. I know that civil society organizations, we are often caught up in the trap of competition because we are competing for very scarce resources. But building effective coalitions that are built on trust, building meaningful relationships is very important, and not only among civil society organizations, but also with media and sometimes with the very government people who are the target of our advocacy efforts.
Thank you, Moses. Very interesting. We have one more question from Jill Gay, who's asking if the global gag rule has impacted your work.
Yes, it did. The global gag rule impacted our work in both negative and good ways. The negative way is that we lost 2 partners who were very strong and very, very effective in, and they were covering about 5 districts for us, and we lost them because they could not sign on the waiver. But Josephine here speaking to us worked for one of the partners on this project with one of the partners. They were going to let her go. And so we said, given the skills, the experience, the knowledge she had, Josephine, can you join us and work directly with us? So Josephine joined us. So that was the good thing, that Josephine stayed and came to work with us. But certainly it impacted us. We had to reconfigure the project in order to make sure that the work continues.
Okay, thank you very much. There's also a question. You shared a lot of results, and it's quite impressive what you reached, like with the oxytocin example. And I was wondering, how do you do monitoring and evaluation of your advocacy work? How do you measure the impact that you have with all the work that you did?
Okay, we have a full M&E department, which we usually do quarterly validation of the data that we get from the community groups and the CSOs. And we also do quarterly check-ins with the civil society organizations. So we also have face-to-face discussions about the monitoring of the program. So we do that with our department, but we also trained the civil society organizations to monitor the impact of their advocacy. So monitoring is done at 2 levels. The civil society do monitor the impact of their work, and also do monitor their work, and also do midterm evaluation, which was done recently, which is supposed also to inform and also help us reshape our project. So monitoring is actually key in this program, and we really think it's very, very important.
Thank you very much. If people have other questions, please don't hesitate. We still have 20 minutes to go. So I don't know if there's any other question from the audience. In the meanwhile, I'd love to hear what your next advocacy target is or objective. What is the main upcoming work that you'll be focusing on?
Okay, we have different plans for different areas. For example, at national level, we are still pursuing with the GFF program to ensure that at least the fridges for storage of oxytocin is honored. And also we have several other areas, for example, in HIV, in maternal and child health, where we're also still continuing advocating for availability of stocks at all levels, at the facility level. We are also advocating for improved supply chain for commodities, for maternal health commodities. We are also advocating for availability of family planning commodities, because recently we had a stock out for commodities for family planning.
I can add at the lower level, which you may call the sub-national level, we still intend to continue with advocacy forums at the lower governing unit, which is the sub-county, where we believe citizens can interface more with the duty bearers, follow up on the previous commitments, and still task them to make difference in whatever advocacy issues that are currently happening in their area. We shall continue to support the advocacy groups in those sub-counties that we mentioned to continue to implement their advocacy action plans. Like we said, advocacy action plans are the heart for this project. It's the heart of community empowerment. That is the only way we can use, or the greatest tool we can use in empowering citizens move off of forefront their issues for duty bearers to take action. We also intend to continue engaging the media so much. The media champions at lower levels in the districts to amplify issues of citizens. We shall continue to bring the issues to attention from districts to national level, so that at least we can create a difference trickling down to from communities upwards and So, and upwards, downwards, we shall continue engaging at all levels, and we believe that will make a difference. And we intend to continue to follow up on the issues that the duty bearers have committed on in different platforms, where we've had like regional stakeholders meeting, we've held Advocate People's Parliament, which is also done in partnership with a media house in Uganda here, NTV. We have held district forums and other meetings with duty bearers. So follow-up is key. We need to track our progress and measure ourselves as we get closer to the end of the project. Thank you.
Thank you very much for a very clear explanation. Another question from Jill. Do you engage with adolescents on advocacy and on their reproductive health needs?
Come again on that.
The question is whether you've engaged adolescents and young people in your advocacy work.
Adolescents and young people.
We are working with the other civil society organizations to advocate for the development of the SRH guidance for young people. We also have a whole civil society organization which was working around availability of family planning for young people. And we also have the same organization working around teenage pregnancy, reduction in teenage pregnancy, and they are also working around having young people in and out of school access quality and the relevant information around sexual and reproductive health and rights. So basically we are working around that, and then the implementation of the guidelines that calls for youth-friendly service provision at health facility. So young people are key in our program, and there are some groups that have young people in there, and they always amplify the voices and the needs and concerns of young people at all levels.
Adding to what Hasfa has said, at district levels, we have incorporated in youth groups, which incorporate the category of the young people into advocacy work, and we tailor their action plans based on their youth needs or the services they demand, like youth-friendly services at facility level, and we engage them in different debates and platforms to present their challenges and concerns to duty bearers. Recently, we had a People's Parliament broadcasted on a national television discussing issues of teenage pregnancy and how the services and how they want to make a difference in their districts. So youth have not been left out, and they will continue to speak out, and that is one of the methods that we have used to incorporate them even at grassroots level, not forgetting sports, dance and drama, where we feel the youth even deliver messages through that, and those activities bring them together into the advocacy work.
Thank you very much. And then we have a question from Sono Aibe. How did you measure the impact for the Sing for Change component, and what were the key evaluation findings?
The Sing for Change campaign was only launched in December, so we haven't fully measured the impact yet. But we have done some, actually in April. April is eventually when we did the actual launch. Sorry, I had given December. So it's too young, too early to measure impact. However, anecdotal evidence indicates that people are hearing the songs, people are tweeting or sending to each other the links for the songs. We are hearing the songs played in public transportation, buses or taxis. We are hearing the songs played on radio, out there spontaneously. So I think the impact is there. On the day of the launch, we had a full house. We had a government minister who listened into the songs, and his speech was very powerful. He promised to make sure that the messages that had been relayed through music would be articulated to the head of government as well as to the cabinet. And the members of parliament have been talking about these songs. Interestingly, actually, a number of conferences that have happened here, international conferences on MCH, reproductive health, nutrition, they all reach out to us and they ask us to bring our musicians to perform as part of edutainment. Even right now, there is an invitation that is pending for the RMNCH assembly. They would like us to have our musicians performing there. So that in itself is positive.
Thank you very much. Now we have Dorothy Anu who has a question. Given the lack of electricity and high bills, what is the sustainability strategy? Recall from a survey from the recent measles outbreak, some health centers did not want UNEP fridges because their bills took a huge chunk out of the PHC funds. So the question is, how did you go about the lack of electricity and the high bills regarding the fridges to keep the oxytocin?
Okay, we have seen several community groups advocating for procurement of solar panels at health facilities. And as we talk now, I can quote more than 5 facilities that have installed solar because of the unreliability of electricity. So solar energy and the panels that they've been procured using the PHC funds, and we think it will help in like addressing the gap of electricity where it is not, and the gap of where there's high bills of electricity. They are now going to resort to using solar for fridges, and they've actually bought solar fridges to store these commodities.
Thank you. And another question from Jill Gay. It's sometimes hard to find healthcare providers in rural areas. How did you work with them? And especially what happened with the physician who used the ambulance for their personal transport? What did you do with it?
Thank you so much. Like I mentioned in the presentation, community groups that we are working with already established community structure were in their locations, meaning the group is already in existence, and they already have their leadership structure, which we work closely with to ensure that the groups are on board and they are well mobilized through their leadership. But even beyond that, we have what we call the advocacy champions, who work closely with these community groups, who are a link between the community group and the duty bearers or the leaders who must make a difference in their action plans, and that is the mobilization strategy that we've been using. But still above all is to work with already existing structures like the VHTs, the local councils here. VHTs are the village health teams. We have the local councils who are the local leaders at that level who help us in mobilizing the communities or even mobilize for other community work that we need to do in those areas.
Thank you. And then we have Mohammed Awal Al Hassan who wants to ask a question. So Mohammed, I'll unmute you. Hi Mohammed, can you hear me?
Hello. Yes, I can hear you. Good afternoon.
Good afternoon.
Thank you very much for the presentation. I think the discussion is something that I think is informative, and the strategies that you've talked about in the presentation are good. What I want to find out is how do government stakeholders at local level respond to some of your strategies? As I admit that you have not conducted evaluation yet, but just to see whether the local authority in your country, just to find out how they are responding to your strategies.
Well, thank you very much. That is a great question. I mean, we have conducted a midterm evaluation of the project. The only thing we haven't done impact evaluation of is the Sing for Change campaign. That was a specific campaign. But as you guessed right, I believe that the question must have been informed by the experiences. Politicians will always think that advocates are inciting the public. Local authorities in some places have accused us of inciting the public to demand for more services than the government can provide. Sometimes we've been linked to the opposition. But we have chosen a strategy of dialogue and not non-confrontation. When the local authorities realize that our approach is dialogue and it gives them an opportunity, we create platforms for them to discuss with the citizens and for the citizens to ask their questions and get answers, and for the citizens to help the government to hold the government officials accountable, then actually they embrace us. They take us on their side. We are in 35 districts. It is only in one district where we have had a little bit of challenge. But even then, it was from a district health officer who himself, I think, was afraid that we might expose him because the people were now beginning to demand for things and ask questions. So, yeah, we've had a little bit of a mixed bag, but overall, because of the engagement strategy we have opted for, not much opposition and resistance. Actually, the Ministry of Health has now approached us and asked us to train them or work with their people to develop advocacy strategies for malaria and for RMNCH. No, the National Health Insurance Scheme. Yeah.
Thank you. Yeah, it feels that you have the Minister of Health right on your side, and he's very open. Do you think elections or political changes could have an effect on the program, or do you think it's sustainable enough to overcome the political changes?
Well, we've already been through a change of government when the project was in its implementation. The person who was the Minister of Health about 3 years ago ended up losing his position. And in one conversation with somebody, he blamed us for affecting his tenure in the ministry. Nonetheless, we think we are not directly to take that blame. If there was a change of government right now, we would still maintain the same approach. We build relations, we network, we share information, we are transparent, we are available, we are non-confrontational. So even if government changed, and we stay with issues, we don't focus on individuals. We focus on issues. We focus on systems. If you are in that system and you're that individual who has issues, then you have a challenge. So we don't focus on an individual person, we focus on issues and systems.
And maybe to add on what Moses has said, change of government sometimes makes people like leave offices, and the people who have already appreciated and they are our support sometimes lose their places, and then new people come in office. So it's like it makes the processes somehow sluggish, and then you have to bring someone on board, like educate that person, interest that person, share evidence with that person, the things that you had already done with the person in office by that time. So sometimes it delays the processes, sometimes you can get someone who opposes your work, but sometimes it requires a lot of education and informing that person about the work that you are doing. But as he mentioned, that most of these leaders at all levels, they have appreciated that ABA, Advocacy for Better Health, has now become the ears and the eyes at the grassroots where they cannot reach. So it's like if you bring the issues, they appreciate that at least you are exposing the people who are not doing their work, and I think they take action according to what we present.
Well, thank you very much for coming to the end of this webinar. I don't know if Moses, Hasifa, or Josephine, you still want to mention something or thing that we haven't been talking about?
No, we are good. Just to thank you for giving us this opportunity to share this experience. We are open and available. Should you require any clarifications, please feel free to shoot us an email and we will respond accordingly. And when you come to Uganda, where everyone is accountable, everyone wins.
Thank you very much. I'll make sure that the recording as well as the presentation will go online in the coming days so that people can still listen to it afterwards or look at the presentation.
Okay, thank you so much.
Thank you very much. Bye-bye.
Okay, bye. Thanks, everyone.